Hello, everyone. Thank you for joining today's webinar, Practical Insights about Creating and Implementing Patient-Facing Digital Health Tools. We kindly ask that you keep your mics muted and cameras off. Please note this meeting is being recorded. If you have a question you would like to be addressed, please enter through the Q&A feature. We will begin momentarily.
Hi, good afternoon. I see some people trickling in, but I think we can go ahead and get started. We are thrilled to have you join our webinar today. My name is Priyanka Desai, and I'm a principal research scientist at NORC at the University of Chicago, and I will be your moderator today. So for those of you who are new to NORC, we are an objective, nonpartisan research organization, and today's webinar is hosted by our Health Implementation Science Center. So we can go to the next slide and see what we have planned for today. This afternoon, we'll be talking about the patient-centered digital health ecosystem, engaging patients in health IT development, integrating patient-facing apps in the healthcare ecosystem, and using patient-contributed data. We will hold all questions until the end of presentations, but feel free to add a question to the Q&A at any time. You should have a Q&A button at the bottom of your toolbar. And now let's meet our speakers. We can go to the next slide, please. So we have four great speakers this afternoon. We'll start with Dean Siddig from UT Health Houston. Then we'll have Angela Dopes from the Crohn's and Colitis Foundation. She'll be followed by Aziz Bakhwala from LMU Informatics. And then we'll have Priscilla Dulab from NORC at the University of Chicago. Next slide, please. And here are our goals for today's practical session. Understand the role of patient-contributed data in digital health tools. Learn approaches to engage patients as partners in tool development, explore how to integrate patient-facing apps with EHRs and clinical workflows, and review lessons learned from real-world pilots. So with that, I'll hand it over to our first presenter, Dean Siddig.
It's so easy to do it while you're practicing. It's great to be here today. And my name's Dean, and I'm a professor emeritus. In case you're wondering, that means I'm old, retired, and not getting paid by the university anymore. And as people were joking today, it also means I have trouble with technology, apparently. So I was working on that right before I joined this. Let's go to the next slide, please. So we're going to be talking about this digital health ecosystem and a lot of the challenges that we've faced and a lot of the opportunities that exist. And this has, tremendous opportunities to transform healthcare. And I think we're seeing that by some of the statements some of our leaders in government are making now. And it's going to take all hands on deck to make this happen. But there's many, many different places where the data that comes directly from the patients can be used, for example, to monitor symptoms and quality of life, for example, by asking you questions about how things are going. You can track patient experiences. I'm sure everyone's got those questionnaires that come from their doctor, say, how would you rate the experience with the doctor and things like that. And that can help the organizations to figure out how to uh, either restructure or fix their problems that they're having. In terms of research and innovation, I mean, we always need data. We always need some feedback, and it's the best to get the feedback from the people that are actually using your systems. And so that's going to be important for us. We think that we can really empower patients by remote monitoring, and this will happen by like maybe sending people home from the hospital earlier and allowing them to be monitored at home instead of being in the hospital. Working on shared decision making so they get a better understanding of what's going on. I think AI is going to play a huge role in this. And then sort of trying to understand more of our population health system level strategies and how we should be running our systems. And for example, who should be getting vaccinations and who should be getting screening tests and things like that. If we could go to our next slide, please. And so collecting all this data and integrating it into systems that we currently use is going to be a challenge. And I've spent my whole career both identifying and hopefully trying to solve some of these challenges. And I think we're going to see a lot of examples today in our talks by some of the different speakers going over several different areas in which we're working on trying to figure out how to get the data from the patients into our systems. And that's going to be a huge socio-technical problem, but it's foundational to the long-term success. I mean, if we can't get the data into our systems, we can't really have patient-generated health data. So that's that. Next slide, please. And so, like I said, there's many different kinds of data. It seems to me there's like two big kinds. There's this one kind where it's sort of collected automatically from you, from your watch or from some sort of a monitor you're wearing, the rings, or I wear chest heart rate monitors and things like that. And then there's other times when they're sort of asking you questions and you're telling them stuff. And so those come in a lot of different flavors of like who's asking the questions and who's putting in the data and things like that. But in general, those are the places we're having this data now. And we've got to figure out how to put it into our systems. We go to the next slide, please. And as I've struggled with my career, I've realized this is really a socio-technical problem. And that means that, it's not just getting the watch to work and getting the battery to work all day long. It's getting people involved, both the people that are wearing the watch as well as the people that are using the data that's coming from the watch. There's going to be different policies about what data we can put into the systems. Um, our electronic health records are always a constraint on us. And then we have organizational, and then there's those care processes in the hospital, and we're going to have to modify those. And there's also processes in the lives of our patient, and we don't want to interfere with those. And so to do this kind of research and to make these kind of innovations, it's going to take a full breadth of different types of researchers and people that are involved and interested in these different types of activities. Next slide, please. And so, like we talk about some of these example socio-technical considerations, and I always think about it's always related to me, if you haven't noticed that. But like I started my career in like the lower right-hand corner with monitoring, and then slowly we started getting into the lower left-hand corner with interoperability, and we thought that was going to be the problem. That was going to be that was a problem, and we're going to overcome that, and we'd figure out how to monitor the data, and we'd figure out how to get it into our system. And as I've gotten older and we've gotten better at monitoring and interoperability, we've realized that there's a lot of clinical workflow considerations that sometimes the people weren't ready to get the data that we were ready to send them. Sometimes the organizations didn't think that they wanted that data, and so we had to go to the governance. And then sometimes patients were worried about their privacy. Then sometimes we just have people like me, these older people that can't get their cell phone to work this morning, and we have this access and digital health literacy, and that's always a problem. And then finally, we have trust and adoption. It's not just trust and adoption on the parts of the patients, but also on the parts of our clinicians that are working. And so, as you can see, we're going to need researchers, we're going to need work in all those areas. If you go to the next slide, please. So, like this is just a short list. Everyone always wants me to just give 5 things. And so here's 5 things that we could do right now to try to get this to happen. We could engage patients. And I think Angela, our next speaker, is going to be talking about that and the caregivers and sort of how to get these systems to work. We're going to have to build some kind of frameworks to try to understand who owns the data, where the data is going, how we're going to control it. We've got to figure out how to integrate the data into our systems. And I think Aziz is going to talk on some about that and some of the challenges that he's overcome on that. This whole AI and you use it with personalized data is going to be huge. And I think that's critical and certainly an unknown that we don't going forward. And then as always, we're going to have some evidence that some of this is working and it's saving money or making lives better. And so I see the next 5 to 10 years as very fruitful for this kind of research and look forward to the rest of the people giving this talk. We go to next slide, please. I'll turn it over to Angela Dobes. and thank you for your attention.
Great. Thanks, Dean, for setting the stage on the patient-centered digital health ecosystem. Healthcare is shifting from an era of standardization towards more personalized care, where the topics that we're going to be sharing today is really helping make that shift a reality. Hi, everyone. As Dean just shared, I'm Angela Dobes, and I'm excited to talk about engaging patients in the health IT development lifecycle. I work at the Crohn's and Colitis Foundation, where I lead a research accelerator platform that integrates comprehensive patient data and biosamples to advance precision medicine innovation. Precision is often discussed in scientific terms, right? The ability to repeat an experiment and achieve consistent results, as in the saying, he's got it down to a science. However, to really advance patient-centered care, it's important to remember the flip side of that expression, which is he's raised the science to an art, right? The science gives us the rigor, but the art reflects the human connection. And so capturing the human connection is especially important in digital health. As the Crohn's and Colitis Foundation works with patients and caregivers to uncover unmet needs and priorities, it's been really inspiring to see patients pushing for better access to health management tools. However, even the smartest technology is only as good as the data it learns from and the goals it's built to achieve, and hence why engaging patients in the health IT development lifecycle is so crucial. Next slide. Okay, so let's start with the why. Why does patient engagement matter in health IT? First, people living with a health condition are experts in their lived experience and can surface needs and constraints often missed by developers and clinicians, right? Only patients know what affects their daily lives, what motivates them, and what gets in their way of managing their health. Let's take inflammatory bowel disease as an example, right? Living with IBD involves managing not only GI flares, but also mental health challenges such as anxiety and depression. And so co-designing tools to address symptoms beyond the gut not only helps empower patients, but enables a more holistic approach to manage disease. Second, co-design improves usability and relevance. So when patients shape technology, the tools become more easily integrated into everyday life and everyday care. For example, for chronic conditions that can flare unpredictably, clinic visits alone don't provide enough data, where tools can help capture data outside of the clinic, like symptoms, which are really critical to improving outcomes. Third, engagement really builds trust and transparency. So when patients are genuinely involved in co-design, it really changes the dynamics. For example, we see this when stakeholder power dynamics are openly acknowledged and addressed. And finally, patient-centered help helps drive better health outcomes. When patients see their experiences and priorities reflected in their care tools, they're more likely to engage, adhere to treatment plans, and manage their conditions effectively. Next slide. So co-design isn't just like a checklist of steps. It's something that must be done with intentionality. In digital health, key co-design principles include patients should be treated as partners, not just participants, right? Build with, not for. Next, co-design is experience-driven and provides the opportunity to include emotional, social, and practical aspects of patients' journeys. In addition, co-design requires iterative feedback loops, right? It's not just this one-time build and test process, but instead enables an ongoing life cycle of continuous improvement. And then finally, core to co-design is transparency around the process and how patient input can build trust and credibility at every step. Next slide. So today I'm going to be talking about an engagement approach that's been adapted from Bird et al.'s generative co-design framework for healthcare innovation, right? This method uses people's lived experience as a resource to shape better models of care. It's really a practical way to inform patients in designing tools so innovations are relevant, they're acceptable, and they're, ready for real-world use. The framework has 3 phases. So pre-design, where users' needs are explored, design, which focuses on generative and evaluative aspects, And then post-design, where requirements are validated. This structured process really ensures that patient voices are integrated from discovery all the way through evaluation. And now I'll just quickly walk you through each one of these phases. Next slide. Okay, so starting with the pre-design phase. This is where like the discovery work takes place and includes activities like user needs assessments, right? The goal here is to help IT developers understand their target populations, how, when, and why patients plan to use the technology, their features, and their functionalities. Depending on the need, different engagement methods can be used. These include surveys, focus groups, empathy interviews. Surveys can help you reach large, diverse groups of people more quickly to map needs and experiences, and they're great for identifying some common pain points and selecting who to involve in like downstream co-design activities. Focus groups enable bringing small teams together to really explore shared experiences and test early ideas. And then methods like empathy interviews act as these like opportunities to have one-on-one conversations that really dig into the lived experience, people's feelings, motivations, life flows to really help facilitate building rich personas and journey maps. And so these methods really ensure that co-design is grounded in real experiences and not assumptions. Next slide. Okay, so then the next is the design phase. Generative design uses mechanisms to explore needs and inspires ideas for tools and prototypes, whereas evaluative design, on the other hand, really tests and refines those early concepts, gathering iterative feedback to improve things like specifications, usability. And so again, different engagement methods can be leveraged. Surveys, which can be used this time around to collect feedback from larger user groups. This helps for things like prioritizing ideas, screening concepts, such as like a tools interface. Consultative groups can be leveraged to brainstorm potential features, based again on real experiences. And then prototype building really helps invite more of a hands-on experience through workshops, et cetera, where users can kind of shape the design of the tool. And so finally, usability testing helps evaluate how well the tool meets the needs through, again, interviews, observations, really, again, trying to pinpoint ways to be more effective, in particular when it comes to accessibility and workflows. Next slide. Okay, so the post-design phase then includes activities like validating requirements with end users. This phase helps build a culture of reflection and iteration. Within the post-design phase, there's engagement methods like consultative groups, again, and then also requirements translations. Just like, again, helps to really close the loop in co-design framework. So we can leverage consultative groups to convene stakeholders after data analysis to validate findings, themes, priorities. And this can be leveraged to help prevent things like drift and ensures requirements truly reflect user and patient needs. And then requirements translations shares essentially like distills results, shares them with groups of people like design specs, roadmaps, and then through things like activities like debriefs, reports, feedback sessions, it really helps then set the tone as far as what next steps look like and transparency throughout that life cycle. Next slide. Okay, so I just wanted to share some final thoughts for strategies for meaningful patient engagement during co-design. First, it's essential to apply health literacy best practices and use accessible language and communication formats so everyone can participate meaningfully. It's also important to recognize patients as true partners and compensate them fairly for their time and expertise. Co-design should also be thought about as being able to be adapted to minimize patient burden using flexible approaches that honor patients' needs and circumstances. It's also important to leverage strong community partnerships with trusted organizations to help ensure tools remain relevant and useful. And finally, measuring and sharing the impact of engagement creates opportunities to ensure continuous improvement, again, throughout this entire life cycle. And really, in combination, these strategies ensure, again, that patient engagement is not a checkbox, but a pathway to meaningful, lasting engagement. And so, in closing, a powerful mantra that I've learned from the patient advocacy community is nothing about us without us. And it's really a reminder that we must co-create the future of modern medicine with patients and not simply just do it for patients. And so now I'm going to pass it on to Aziz to share a little more around what he's doing to help integrate patient-facing apps into the healthcare ecosystem. On to you, Aziz.
Thank you so much, Angela. So good afternoon, everyone. And I will be sharing some of our experience in integrating patient-facing apps into with tools in the healthcare ecosystem. I with a company called Alimo Informatics, and my work has been around developing standards and using those standards to build clinical decision support tools and patient engagement applications. Next slide, please. Thank you. So why do we want to integrate apps, patient-facing digital health tools with clinician-facing tools like EHR, right? So often we see when clinicians have used digital health tools with their patients, they're kind of moving out of the EHR, logging into a separate website, or looking at data that the patient brings to them printed out on their phone. And this creates kind of a break for them from the workflow. It creates usability challenges. It creates issues with having the data integrated into one view so that they can make better decisions, both clinicians and patients, right? So when we integrate these digital health tools with the healthcare ecosystem, with EHRs, with population health tools, it starts unlocking this potential of using all of this data, using all of the patient kind of a more collaborative patient care, healthcare experience, right? Seamless workflows, just better decisions made overall. Next slide, please. Thank you. So what are some of the challenges we face, right? So when we start using more digital health tools, currently it's all fragmented, right? So the EHR population health tools, they're not really well integrated, as I mentioned earlier, with these digital health tools and with these patient apps. And as we add more tools, you're just creating more and more silos, right? Now, the other problem is with the standards adoption, so there are standards to help integrate these tools with EHRs, but the adoption in EHRs, implementation, availability of standards within these on the healthcare IT side has started off. It's still low, in my opinion. On the patient sort of facing digital health tool side, it's even worse. It's kind of almost absent, right? So we need to increase that adoption. Then there are new concerns emerging from privacy and security because of these tools, how the two sides of this framework can exchange data with each other, how policy issues, regulatory issues that are emerging because of these. Then there is the ability to scale. How because of all of these issues that I just mentioned, it's harder to scale. I mean, it's each implementation, each deployment is kind of a one-off experiment almost. And then scaling clinically to have a large number of patients use this becomes a challenge because the integration is so poor. Right? Next slide, please. So this kind of infographic shows what we mean by the integrated digital health ecosystem. So on the left-hand side, you see the healthcare team, and this includes your physicians, nurses, health coaches, maybe dietitians, others who are trying to address the patient's healthcare needs, right? And they support the patients in using the app. They will review, respond to data from the app. They'll engage with the patients in shared decision making, helping make decisions that are kind of jointly with their patients, right? They typically use tools like the electronic health record, population health management tools. Right? On the other side is the patient and their caregivers, right? And they're engaged in that shared care planning process as well, and then kind of trying to follow that care plan, right? Uh, they can use those digital health tools to receive recommendations for their care, receive decision support, communicate their needs with the healthcare team, and then share data with their healthcare team as well, right? And they can review their data, they can review recommendations, they can again, they also make joint decisions jointly with their healthcare professionals, right? And they'll be using the apps, they might be using devices, wearables. And then in that middle box on the lower side, you can see the kinds of data that are exchanged. So the kinds of data that should be exchanged include information about enrollment, about the clinical data from the digital health tools that the patients have contributed, the engagement, the care plans or the engagement plans, insights and recommendations, notifications, alerts, those kind of things. Uh, and then questions from the patients or requests from the patients that the clinicians may have to respond to. Okay. Next slide, please. Right. So we, in a prior project in the Clinical Decision Support Information Collaborative, we identified 5 different scenarios or 5 different really activities in the workflow where uh, interoperability is needed. So one is during enrollment, right? So the EHR and the digital health tools should be exchanging information about enrollment. So the clinician would like to, and the patient have agreed that the patient should use a certain digital health tool. Maybe the clinician could create an order in the EHR, and then that should flow using standards into the digital health tool, and the enrollment ensues. And if the EHR should know if the patient's what the patient's done with that enrollment. Have they consented to the use? Have they, have they actually, decided to unenroll themselves, right? So that kind of information needs to be exchanged. Then, the healthcare team reviewing data that's coming in from the app. Like I mentioned earlier, sometimes clinicians have to go out to another website and review that data, and they're seeing that separately from the EHR. Could that sort of data be integrated into one view, both the clinical data and the patient reported data or the patient shared data, right? All of that should be available in one view. Decision support and population level analytics. So right now, the decision support from EHRs is primarily based on data from the EHR. Decision support from the apps is based primarily on data from the apps. They don't really exchange data with each other. I think the decisions might be better quality if we had better integrated data, right? And same thing with population level analytics. If you could again, a similar sort of reasoning applies. Like if you could integrate data from both sides, we might be able to understand our patient population better. And then on the workflow side, notifying healthcare team of things that might be happening in the app. Patients shared some data that's, indicated a significant health concern, like a very high blood pressure value. Or notifying patients about something, the clinicians wants to change their care plan or wants to set up a new appointment. Those kind of information needs to flow between all of these applications, right? And are there standards available for these, and are they adequate, right? That's the question. So if you go to the next slide, right. So there are standards. I think there are standards. There are certain gaps in the standards, but there's kind of enough to get started, right? So the base currently, the kind of the standard that's widely used for interoperability or increasingly being used for interoperability is the HL7 FHIR or Fast Healthcare Interoperability Resources. And what this allows these providers a set of APIs for exchanging data between systems, for example, between EHRs and patient apps. And this allows for structured exchange of information like health concerns or problem lists, medications, prescriptions, laboratory test results, patient-reported data like patient-reported outcomes or PROs. All of those can be exchanged with FHIR. Right? Smart on FHIR is a related standard that allows apps to integrate with EHRs or with other health IT systems as well. And what that does is provide, and this can be patient-facing apps, can be clinician-facing apps. So both can be integrated with such Smart and FHIR. And Smart and FHIR provides mechanisms to authenticate, to authorize access to data. And then it uses kind of the FHIR resources I described on the left-hand side to be able to exchange data, both be able to read data from systems and be able to write data back as well and update data. Right. CDS hooks is a standard for EHRs today, at least, to call external clinical decision support systems. And those calls to external decision support systems are triggered by various things in the workflow, like a clinician opening an EHR, a patient's record within the EHR, or clinician creating an order for a medication, a prescription for a medication. Those would trigger calls to an external CDS system. The external CDS system can access not only the data from the EHR with this call, but can also use its own data. So patient-facing apps can combine when called from using CDS hooks, can pull their own data and can also access EHR data and provide decision support to clinicians. A notable gap today in CDS hooks is it's all the triggers that are defined are clinician-facing triggers, and there are no patient-facing sort of triggers that would be useful for patients to use. And then there are implementation guides. So there's a lot of implementation guides. They are specific to different scenarios. So there are implementation guides, for example, for exchanging patient-reported outcomes data. There's implementation guides for exchanging blood pressure data. And these, what they do is they take the base FHIR standard and they add constraints. They say, for exchanging blood pressure, we shall use these specific lowing codes. One of the most, I guess, widely used implementation guide in the US is the US Core Implementation Guide, which sort of says defines the FHIR APIs that EHRs in the US provide with more specificity than the base FHIR standard. And that's been, in my opinion, has been very helpful to get consistent access to data from EHRs. Next slide, please. Thank you. Right. So I'd like to describe this app, one of the apps we developed and we integrate with the EHRs. This was back in 2020, in the fall of 2020. And the purpose of this app was to be able to help monitor patients. So clinicians monitoring patients who have tested positive for COVID, but were at home. They weren't hospitalized, right? So monitoring a large population of patients, and right. So the benefit for the clinician was they were kind of reaching out to patients through phones and through portal messages and such. And so this was enabling them to kind of be able to monitor a larger group of patients. And for the patients, this was allowing them to share data with the clinicians, to receive feedback from the clinicians about what to do next. This is before, if you recall the timeline, this was before there were vaccines. So there's just a large group of population. We were still doing 6-foot separation and all of those things. So the healthcare system was kind of stressed out with the workload, and patients were unable to go visit their physicians, or it was kind of recommended not to visit physicians. So this app had kind of a need that was serving both populations. We built the integration using Smart and FHIR, HL7 Smart and Fire app, and I'll show a couple of screenshots in the next slide about how that worked. So clinicians enrolled the patients using a Smart and Fire, clinician-facing Smart and Fire sort of workflow. When they did that, the patients received, and this was the enrolled patients who had tested positive for COVID already, but were at home, right? And when they did that, patients received daily text message reminders to share their data. And with that text message reminder, they got a link to share their data. When they opened that link, they would see a form like you're seeing on the left-hand side there that allowed them to share this data with clinicians. So things like your body temperature, oxygen saturation, and such, and some symptoms. On the right-hand side, you're seeing a view of the EHR, and in the lower half, you see the patient report, same patient-reported data on different days. And in the upper half shows the population of patients they're monitoring and color-coded sort of risk levels. So, it's like the patient in the middle of that deck with a risk score of 8 probably needs more urgent attention than the patient with a risk score of 2 higher up. We were able to integrate this app with the EHR using FHIR. So we were able to collect data from the patient, create a FHIR questionnaire response, and post that data to the EHR and made that available to clinicians. So, and this integration, all of this work we were able to do this in a matter of 2-3 months, be able to build an app and deploy it and integrate it, all of that. So standards were very, very helpful in terms of being able to integrate the app with the EHR. Next slide, please. Thank you. I think this is, so I'd like to end with some recommendations, and there's recommendations for different constituencies here. So for EHR vendors, it's really being able to, providing more support for standards, more FHIR resources, and more the ability to write data back into the EHR, because that's what the clinicians keep asking us for, right? From a security perspective, just being able to handle group level access rather than individual level. I can elaborate on that later if someone wants to know more about it. Being able to notify clinicians, and that's where those FHIR communication APIs come in, and support more non-interruptive notifications just for better workflow. For app developers, I think it's just really use all the standards that are available. So use FHIR APIs, use Smart and FHIR to integrate your apps. And use CDS hooks where it makes sense to notify clinicians. Healthcare organizations, when you integrate digital health tools, ask for those in your, ask your vendors to provide the standards-based integration. Right? Security, you can streamline vendor security assessment. That's a big kind of just impediment right now to implementing apps in the sense that it just takes a long time. It's a necessary thing to do, but can be streamlined. Require that the apps be integrated with the EHRs. Require the vendor to integrate the apps with the EHR and support that integration process. And for policymakers, really, expand US Core to support some of the, more patient engagement. I think critical to that is being able to write more data back to the EHR to support subscriptions. From a security perspective, text messaging and the privacy around that, and then also communication API, so we can have those apps and the talk to the clinicians, talk to the patients more. And with that, I am going to pass it to Priscilla. Thank you.
Thank you so much. Hi, everyone. I'm Priscilla Dulab. I'm a Vice President and Fellow at NORC at the University of Chicago, and I direct NORC's Health Implementation Science Center. So I would say we are at a very exciting time in healthcare as technology finally seems to be enabling all these different models of virtual care. But I'll be talking about what we learned in what it really takes to make it work. So I'll be sharing findings from 3 real-world pilots where we tested different digital tools. These were not theoretical exercises, but implementations with patients and healthcare systems. And I say with patients and healthcare systems. And what we learned in picking up on some of the themes that Dean surfaced early on is that the technology is only part of the story. I will say that the success depends on the people, the processes, and the environment where these tools are deployed, and we refer to this as the broader socio-technical system. I think these pilots also shed some important lessons learned on what works, what doesn't, and what we need to do differently. So next slide. So all three pilots that I will be discussing were funded under the Agency for Healthcare Research and Quality's project called the Clinical Decision Support Innovation Collaborative, which I had an opportunity to participate in. What makes these pilot projects interesting are a couple of things. One is the variety. We tested things from text messaging to sophisticated AI chatbots. We used different clinical settings with different use cases. So starting on the left, I'll talk about the Quartz app. This app was designed for medication to assist patients with hypertension in their medication management. As you know, medication non-adherence is a huge problem. When patients don't take their medications as prescribed, it leads to 2.5 times higher odds of hospital readmissions. And I think when we checked, it costs the US healthcare system over $500 billion annually. So the Quartz app was designed to help patients better manage their medication, particularly in the context of hypertension. I'll also talk about the hypertensive disorders of pregnancy monitoring app, in short, the HDMP app for new mothers. Hypertension affects at least 1 in 7 pregnant women in the United States and is the leading cause of maternal death. Yet after giving birth, follow-up care for patients often falls through the crack. And then what this app was designed to do was to submit daily symptom questionnaires to patients to collect blood pressure readings and to report any warning signs that they may be experiencing to their care team. And then finally, I'm going to talk about Page, a chatbot that was developed by Vanderbilt University. And this uses artificial intelligence to improve how both patients and doctors communicate. So instead of those back and forth portal messages, the chatbot asks clarifying questions and creates a structured summary that both patients and clinicians can review. And for each of these pilots, we conducted evaluations. So what I'm sharing today are the findings from these evaluations. And what you'll see is that, we'll describe the good, some of the challenges, as well as the unexpected things that we discovered along the way. Next slide. So starting with the Quartz app. So how this works in practice. After a patient enrolls, the app sends a text message asking them to measure their blood pressure and reminds them to take their medications. And we set the frequency of this messaging depending on, different stages of patients and how controlled they were with respect to their hypertension. Patients respond with their readings. They answer a brief questionnaire about any barriers they have in terms of taking their medication. In some cases, patients reported that they were not taking their medication because it made them feel bad. Maybe they couldn't afford it. Maybe they were feeling better and they felt that they didn't need the medication. The app used natural language processing to gather information about both their medication adherence as well as their blood pressure readings. This is an interesting pilot in that the information that was received from the patient was then placed in a dashboard for the clinician. So in one place, the clinician could see information that came from the patient in terms of their blood pressure readings from the health system, medications, any reasons why the patients reported not taking the medication, so they had a comprehensive view. And then when something needed attention, the clinician was able to intervene. And this created sort of this continuous loop of monitoring and support that extended obviously beyond the 4 walls of the clinics into the patient's lives. So next slide, I'm going to share some highlights in terms of lessons learned. So the first was that leadership makes or breaks adoption. Our clinical champions were actually absolutely essential. Some patients, not surprisingly, were hesitant about the technology, and understandably so. But when their doctor said that, I think this could really help you, we saw lots more of receptivity to participating in the pilot. We need new workflows, not just new technologies. I know this sounds super obvious, and I know we've been talking about workflow issues in healthcare and digital tools for a long time. But what we heard from the clinical teams as part of the evaluation is that they need clear guidance, who monitors this incoming data, how quickly they must respond, what constitutes an emergency versus something that can wait. And really, here is a potential where I think some of the AI tools that are starting to emerge, can be tremendously helpful, both in terms of creating alerts and suggesting appropriate responses. So we do see that remote monitoring enables timely care and patients actually see value in it. From our evaluations, we heard that clinicians could respond to problems much more quickly in days instead of weeks. We heard directly from patients how much they value this. As one patient told me in the evaluation, I like knowing my care team is thinking about me even when I'm not in the doctor's office. Um, the technology, while we are seeing some promising signs, is not all the way there yet. Current standards and EHR capabilities have some gaps. Aziz talked about that at length. But what I will surface is that getting patient reported data, like the blood pressure data, back into the EHR was a lot harder than we thought. And even as we sit here right now, electronic health record vendors can't easily distinguish, some electronic health record vendors can't easily distinguish between readings that are taken at home versus those that come from the clinic, versus those that come from the clinic, an important distinction when clinicians are trying to make care decisions. And so we use certain workarounds to try and, accommodate for some of these limitations. And then finally, the cost and sustainability concerns are real. So while we saw enthusiasm from both the clinicians and the patients, some of the resource constraints were also surfaced as part of these pilots. Smaller community practices struggled with the clinical staff needed to monitor the data, providing technical support, and then maintaining the technology. So we definitely need better models for sustaining these programs over the long term. Next slide. So I'm going to transition and now talk about the HD PMP app, okay, the Hypertensive Disorders of Pregnancy Symptom Monitoring app. So despite the high risk of hypertensive disorders of pregnancy, postpartum monitoring is often inadequate. So in addition, like many of the solutions that we saw out there were only recording blood pressure readings from moms remotely, but it also, it misses some crucial information. And what our pilot was trying to do was really to get some blood pressure readings from the mom, but also to collect information about symptoms that they may be experiencing. So things like headaches, vision changes, or upper abdominal pain, warning signs that there might be something else going on with the hypertension, with their hypertension, and that needed to be managed. So what this did was that the hypertension app complemented the blood pressure monitoring by regularly sending out questionnaires to the mom, so they would get a questionnaire every day. They were able to report their symptoms at a time that was convenient for them, particularly important when you think about, a new mom caring for, her little one straight after coming out of hospital. The app was able to integrate findings into the EHR using the FHIR standards, and Aziz spoke about those. And then, when there were symptoms that were worrisome, the clinicians were alerted and they were able to respond in a timely manner. Next slide. So what did we learn from this particular pilot? There were some lessons that resonated from our prior pilots, but then there were also some new insights. So first, clinical champions, again, were quite important, not just for getting the pilot started, but for sustaining the engagement over time. Second, particularly for this one, implementation coordination across the care teams was quite critical because the pilot involved the clinical teams, hospital IT teams, electronic health record developers, third-party app developers, and we needed to have clear roles and responsibilities in order to, quickly implement the solution. Third, we learned that patient engagement in design is non-negotiable, and I know Angela spoke about this at length. But despite incorporating patient feedback into this app, we still found gaps, particularly in this patient population. So we really needed to understand what motivates patients to continuously use these types of tools to report their systems. And we needed to get deeper insights into their daily life flows in order to see how this could really work. Fourth, while I would say the FHIR standards helped us, it definitely helped us get the solution up and running faster. We still encountered challenges, and again, for some of the reasons that Aziz spoke about. And then finally, another important finding from this pilot was, sometimes you don't really need all of the data to be written back to the EHR. When third-party apps are appropriately integrated into the EHR as part of the clinician's workflow, clinicians can view and manage patient data effectively, even though the data is not within the EHR. So something for us to keep in mind moving forward. Next slide. So now I'm going to transition and talk about the PAGE pilot that we conducted with Vanderbilt University. as you know, if you've ever messaged your doctor through a patient portal, you know it's frustrating. These messages go back and forth asynchronously, they get scattered. Doctors receive lots and lots of these messages every day, and it's inefficient for everyone. So what Paige did was it uses large language models to streamline this communication. The patient starts with a question or a concern. The chatbot asks clarifying questions. What symptoms are you experiencing? When did they start? Have you tried anything? And then he guides the patient through a structured conversation. And then once the patient responds to all the prompts, the chatbot creates this concise summary for both the patient and the clinician. And there's a way for the clinician to take care of the patient based on the inputs that they are receiving. So what did we learn from this pilot? A few things. So the good news is that the patients found it easy to use. The language was written at appropriate reading levels, and the conversational interface made it easy and made sense to people. And we think this is obviously quite critical for broad adoption. Clinicians found value in these summaries. They strongly agreed that the summaries captured the patient's questions and concerns. And in many ways, they preferred these summaries to the scattered patient portal messages that they were receiving. But we need to be more patient-centered, and I want to stress this. We heard from patients that the AI summaries could be better. Rather than automatically translating everything into clinical jargon, it should preserve more of the patient's voice. Like when a patient says, my head feels like a vice, that communicates something different than saying, I have a severe headache. We also heard from patients that they would like to get some educational resources while they're waiting for their clinicians to respond, and that we have to be thinking about patients with different health and digital health literacy levels. And then finally, particularly for these types of tools, there needs to be a tighter integration with information from the EHR, so there's context when the patient is getting some information and having this interaction with the LLM. So I'm going to wrap up with some cross-cutting lessons, and I'm going to summarize them quickly. But I will say that, clearly clinical champions are non-negotiable. We need to rethink the workflows, particularly in the context of these evolving virtual care models. Co-design, as we mentioned, is essential for patients. They clearly told us what they need: help with onboarding, ongoing monitoring, timely feedback from clinicians, and technical support when things go wrong. Patients are clearly more motivated to contribute data when they know that their care team is actually paying attention and will respond. And if we design tools without meaningful patient input, they will not get used. We talked a lot about the technical infrastructure, so I'm not going to belabor that. I would say two other critical areas: EHR developer resources, such as test beds that incorporate patient data, and better documentation. And then finally, patient education and support. And then I will wrap up by saying that we need to demonstrate value. Hospital leadership, like CFOs and others, need evidence that these tools improve outcomes to justify their costs. So in sum, I will say that there is a path forward. It is not without challenges, but the potential to transform care, to make it more responsive, more personalized, and more effective definitely makes this work worth doing, which I strongly believe. So with that, Priyanka, I'm going to hand it off to you and we can open up for Q&A.
Thank you so much, Priscilla, and thank you to all of our presenters. So, folks, we have some time to do some questions and answers. So if you have any questions for our presenters, feel free to enter them in the Q&A box. And we've taken down the slides so you can see us all better. It looks like we have several questions in the Q&A in terms of whether the webinar will be available after this session, which is a great compliment to our speakers. We will certainly share the webinar slides after this session. And the good news is you may have seen the superscripts throughout the slides. We do have references and a detailed reference list, including findings from our pilots available for everyone who's attending today. And I see one follow-up in terms of asking a question about accessing app data within EHR workflows without having write back. It was a very intriguing point. So I will turn this over to the speakers.
So I'm going to start responding, and then Aziz, I would like you to weigh in on this a little bit as well. So as I mentioned in our different pilots, particularly when it came to writing symptom data that the patients were reporting back to the electronic health record, oftentimes we found that it was very difficult to do that. So the alternative was to have the app capture the information and then have it embedded within the electronic health record. So it fit into the clinician's workflow, but the data wasn't being written back into the EHR, but rather being accessed through a third party server. So that's how we sort of worked around that issue. From the clinician perspective, the experience was seamless. So they clicked on something, they saw all of the information presented to them in a way that made sense. But in terms of where the information was sourced to be delivered within the dashboard, it was not coming from the electronic health record. Aziz, do you want to add anything more to that?
No, I think you covered that right. So it's a Smart and Fire standard, and that allows you to essentially open a tab within the EHR and see data. And what we did with our apps was the Smart and Fire apps that open within the EHR would pull data both from the EHR and from the patient apps, and blend them in a way that kind of was seamless. So you'd see blood pressure recording, both like patient reported and clinical blood pressures on one graph, right? So you didn't have to kind of you switch between screens and such.
Great. Thank you both for your answers to that question. We have a follow-up in terms of recruiting patient and care partner co-designers, particularly those who aren't expert patients or enthusiasts or outliers. There's comments in terms of encountering challenges for arguing for paying patient co-designers fairly as well. So appreciate your thoughts on that.
So I'm going to start, Angela, then I want you to respond as well. So I want to pick up on this, and I think it's an important point. So we did it in different ways. As part of our decision support innovation collaborative, we definitely had patients with lived experiences participate in the project, and we engage with them. But then we also engage with a much broader community. We actually engage with patients within the delivery system to also help us think about the app design and what was needed. In all cases, we compensated the patients for their time. And I think that is quite important to do, both for their, interesting insights and value, but also, taking time out of their lives to help us. So, Angela, I'm going to hand it off to you to comment further on that.
Sure. Yeah. And it's a really important question because you want to be able to get a broad scope of feedback across, the patient continuum. I can tell you one thing that's really helped the Crohn's and Colitis Foundation in particular when it comes to compensation is we have leveraged, the National Health Council has a fair market value calculator that's a part of their like patient compensation tools, and it basically guides companies on what that right dollar amount is and why, with a lot of evidence behind that as far as emphasizing the need to treat patients as partners and compensate.
Great, thank you both. And I think we have time for one more question. So I will pick one in terms of, is anything being done to coordinate this with HL7? I know Aziz and Priscilla, through our work with the Clinical Decision Support Innovation Collaborative, we have had opportunities to engage HL7. So perhaps you could speak to that.
Please, can you talk about the taxonomy and HL7? I think that would be quite compelling.
So I'd say there's probably been at least some informal communication with HL7. So I participate within HL7 work groups, and I share feedback with both within the work groups, but also with other sort of EHR vendors and such who actively participate in some of the HL7 work groups. I think Priscilla, you mentioned we had created a taxonomy of CDS override reasons, and reasons that clinicians or patients might provide for not following the advice generated from a clinical decision support system. And we're sort of working with the HL7 clinical decision support work group now to make that part of the standard, so that, for example, within CDS hooks, that taxonomy could be utilized to provide override reasons. And right now there is no standard sort of for that capability, and so this would cover that reason. But as you know, I mean, standards move slowly, so this kind of work just takes a long time to start surfacing there.
Well, thank you, everyone. I realize we are at time. 60 minutes goes fast, but I do want to thank everyone for attending today's webinar. Our information is on screen if you'd like to learn more about the Health Implementation Science Center. And we also have the email addresses for all of our panelists and myself in case you have any follow-up questions. Apologies for not getting to all of your great questions, but hopefully we'll have an opportunity to engage in the future. So thank you again for joining us this afternoon. And as I said, we'll be sharing our slides after this webinar. Thank you again.